Hello everyone, welcome to the fourth episode of MDSI-Vaani. Here we interview the authors of landmark research articles on movement disorders from India. I am Dr. Kuldeep Shetty. I am a movement disorder consultant at Narayana Health City, Bangalore. I shall be interviewing Dr. Pettarusp Wadia, who is the senior movement disorder consultant at Jaslok Hospital, Mumbai. So today we have Dr. Pettarusp Wadia as our guest, and today we'll be talking to sir on the landmark paper which has been recently published in AIN, that is the spectrum of movement disorders in movement disorder clinics across 3 cities in India. So it's a tale of 3 cities. So welcome, Wadia sir.
Thank you. Thank you very much, Dr. Kuldeep, for inviting me here. And I think so this paper was conceptualized in a very unique way where we were just sitting and chatting about it. So I think go ahead and we can discuss this further.
Yes, sir. So first of all, I would like to come to the first question. Sir, how and when did you plan this study? It looks very strategically planned because it involves a center from east and a center from the west and a center from the south. So how and where did it start, sir?
So although it looks planned, it was totally unplanned. So it just happened that we were actually sitting on the sidelines of MDSI Hyderabad in the evening after something, just sitting and relaxing in one of the rooms of one of the three of us, and we were just discussing, and we were all discussing how we are maintaining records, database, etc. And we realized we are all maintaining an electronic database, capturing almost all the same data points. So the points was, if we are doing all that, why don't we collectively see as to are there differences in certain diseases in certain centers, or are we sort of like having a similar profile of patients? And what is the most predominant disease that actually shows up in the patients that come to a movement disorder clinic, depending on which city they're coming from? So that's exactly, I think, how it started out to some extent.
Okay. Okay. So it is one of the biggest epidemiological studies from a movement disorder clinic setup, sir. And also it is clearly one of the studies with the longest follow-up. So what are your advices to young researchers in terms of data collection? How do you advise young researchers to keep a track of their cases in such setup?
So I think we all had kept electronic records. I actually have my records right from the time I started the movement disorder clinic, or either took over the movement disorder clinic in 2008. And
Great.
it really helps in many ways. It helps in keeping a track of your follow-ups. It helps in understanding what you're dealing with, and it definitely helps in research. And if you look at the today's scenario, you look at what the entire world is looking at, the Googles, the Amazons, and they're basically capitalizing on the data they have. Zomato's IPO, which is being released right now, is highly probably overpriced on the data they have. So data is to go. So we all need to keep data, but at the same time, when you put data, patient data is very different to the way data is handled in most of these settings, which I mentioned earlier. So I think your data privacy is very, very important. It's also important how you're going to store that data, and it's ensure that that data doesn't get leaked, because I mean, after all, there's a lot of patient confidentiality concerns that we have. So I think my suggestion to the next generation is keep records of all your patients. Have a system of how you're going to even classify the data. ICD coding is probably ideal, but if not ICD coding, at least have some methodology, maybe the phenomenology group, then the subclassification, and have a system where you ensure that you don't duplicate the data. The patient came to you once and he comes back 7 years later and says, oh, and he just forgets that he had even seen you at that time. You should ensure that you are able to avoid that duplication. And your system should be robust enough to ensure that, okay, the name appears twice, you will deduplicate it. So over the years, I've learned that you have to capture a lot more data that you need. So when you capture the name, you capture the the surname, you capture the location where you're recording the data, where the patient comes from, and you capture the middle name. So when you have all these data, that's when it helps you.
So that's really a great piece of advice, and I think all the young movement disorder specialists will keep that in mind. So, sir, coming to the study, what were the crux observations in this study, sir?
Okay, so I think I'm going to share that slide with you.
Yes.
Yes. So I think I'll just put it on PowerPoint.
Yes.
Yeah, can you see the slides? Are the slides visible?
Yes, sir. Yes, sir. It's very clear.
So this is a spectrum of movement disorders in a tertiary care center in India, a tale of three cities, and it is so as we told you, and the four authors are Dr. L.K. Prashant, Dr. Rishikesh Kumar from Calcutta, Dr. L.K. Prashant from Bangalore, myself from Mumbai, and Dr. Muthane also. And these are the three clinic locations. If you see, bulk of the patients obviously are from the same state, but a lot of patients are from the neighborhood. Gujarat, 800 patients, Madhya Pradesh, Rajasthan in the west, in the south, large patients from Tamil Nadu, Andhra Pradesh, Telangana. When you look at West Bengal, fair amount of patients from Jharkhand, Bihar, Odisha, and of course the Northeast. So, so there is a lot of patients in the areas around it, but then there are a lot of patients even from as distant as Jammu and Kashmir, 5 patients which are geographically miles away from this area. And then you have patients so from the Northeast, far-flung regions. So we've literally covered the length and breadth of the country between the three centers. Obviously, North India representation being lower, but because none of the clinics are really situated in North India either. But I would say this is fairly representative of the situation within the country. We had a few international patients, but that's a very, very small number in the big numbers. And as far as diseases are concerned, the three most common diseases, Parkinsonism forms 63%. That's a huge number. Dystonia, 14%, and tremors, a mere 7%. When you look at it, actually, tremors are way more common in a epidemiological population-based survey. But obviously, tremors are not necessarily something that you need to refer on. It can be treated probably at a primary level, or patients don't think it's important enough to see a specialist for something which is not so bothersome and not so affecting their quality of life. Another thing that we didn't see in a big number is restless leg syndrome, where only 1% of the patients with restless leg syndrome. This is a very small number compared to what we would have expected for a large population of patients. So I think the highlights of the data, I would say common diseases, high prevalence of atypical Parkinsonisms. 22% of all the patients in the study had atypical Parkinsonism, PSP, MSA, basal syndrome, and some where we were not able to clearly see. Very high proportion of patients with dystonia, probably because they're referred for specialized. I mean, double the number of dystonia patients as compared to tremor patients. As I said, very low prevalence of RLS, and this is, I think, something which I'm very concerned about, is ensuring that we recognize RLS, we treat it, because I think this is a disease that's so rewarding to treat, at the same time so unrecognized. And as I told you, low prevalence of tremors. One is maybe managed at primary level. Two, maybe don't think it is important enough to see a specialist for tremors. So this is just something that we've seen in the study, and we are reporting it. Amongst the rarer diseases, Wilson's, as you know, is a relatively common disease in India, but in our cohort, fairly uncommon. But then you might realize that Nimhans in Bangalore is a large Wilson center, and Kokilaben Ambani has a large Wilson clinic in Mumbai, both of which are at locations which are not in the three research centers. So probably a lot of the Wilson patients may be going to elsewhere, and that's why the numbers are lower in our study. SCA 12, we had large number of patients, 180, of which 80% were really from Kolkata. I mean, large number from Kolkata, 80% presented with tremor. Now, Kolkata has a high number of SCA12 because they have a dedicated SCA12 support center as well. But having said that, I think 80% of these SCA12s presented with tremor. So I think you really have to think of SCA12 when you're thinking of tremor. So in a patient with tremors, you have to think of SCA12 as a differential diagnosis, especially if the patient belongs to the Agarwal community or if the patient has additional features of ataxia, you have to think of SCA12. Korea was found in very, very small proportion, only 11 cases out of the 14,000, indicating that probably it's probably gone down because of rampant antibiotic usage and probably also better hygienic conditions in the country. Compared to that, Huntington's chorea formed 0.4% of the cohort and Huntington phenocopy is 0.4%. So we are seeing much, much more of Huntington's and Huntington phenocopy disorders as compared to rheumatic chorea. One limitation of the study is that this study was done in private centers, not in government centers. So it could be possible that there is some bias because of the difference in private versus government centers. But on the whole, I think we all think that rheumatic chorea is reduced in compared to what it was probably a couple of decades ago. Functional movement disorders, very small numbers, only 0.6% of the cohort. Compared to, I mean, the Western population where functional movement disorders form a much larger proportion, it seems like a lower burden. Question is, are we diagnosing enough? Or is it the fact that there is lack of compensation? So really having a functional movement disorder, that the occupational gain is not there. And there's lack of anyway social security that's going to help you if you had a major disorder. But I think really we don't understand too much yet on this data. And I think it'll be interesting to see if this is replicated in other studies. So I think I'm going to unshare at this. I'm going to stop at this.
Yes, sir. Yes.
Anything else you want to know about the study?
No. Yes, sir. So, yes. So, can you unshare, sir? Yes. So that was really very crisp summarization of the entire study, sir. Really, thanks for that. Sir, both from your personal experiences from the West as well as from the literature data. So what do you think, sir, is the difference between the movement disorder patterns in movement disorder clinical setups in West versus in a country like ours? What do you think is the main difference?
So the clinic setups, I think, are very similar. But obviously the patient profile or the patients that come to these centers seem to be different from these studies. I'll just share one slide to you.
Yes.
So this is a study from, this is a slide, a table from the same article. So these three studies, our study, Pan and Yankovic, and the study from Nigeria, all movement disorder clinic studies. Now, we have the highest proportion of Parkinsonism in our study. Nigeria not very far out at 54%. While tremors, we had lower proportion of tremors compared to both the groups. And as I mentioned, RLS much, much higher in the US study. The dystonia proportion seems to be similar in ours and the Nigerian study, a little higher in the Fan Yankovic study. So I think that there seems to be a referral bias in the developing countries towards more Parkinsonism. Nigeria is also a developing country like in India, so it's like it's more tilted towards Parkinsonism being referred on to the movement disorder clinics. The tremors coming to the clinic is very, very low in India. Probably, as I told you, two reasons. One is being handled by the general neurologist and don't need a second opinion, don't need to be referred on, or there don't seem to be any reason to refer them on. And also maybe patient perception. In India, the patients with severe tremors also tend to say, oh, we don't want to go ahead with surgery because you have help but do a lot of things for you. While in the Western, you have to live an independent life. So it's very important for you to have your hands steady and being able to be independent and do everything on your own. We don't know what differences really are, but I think perceptions, many of the elderly patients with bad tremors, I've told them, we have the option of considering deep brains. Most of them don't seem to be even remotely interested in it.
Yes. Yeah. Yes, sir. So, as you rightly pointed out, sir, that there is a significant referral bias. It seems that at least that there is a significant referral bias for Parkinsonian syndromes. What do you think is the reason for this? Do you feel that it's some hope with the high-end therapies and the apomorphine infusions like that? So that is the reason for referral bias.
So there are referral biases. One is there are a lot of patients who have atypical patterns, which form 22% of the cohort, which are not doing well. So then there's always the hope that, okay, we might do better if you go to a better center. So better diagnosis, better treatment. Then, of course, also DBS. Apomorphine infusion was not there when the study was done. The duration of the study, apomorphine had not been launched. So apomorphine was not there at the time of the study. DBS, yes. But a large proportion of patients, in my own experience, which are referred for DBS actually have atypical Parkinsonism phenotypes. I also feel that different to the US setup is in the US setup, you cannot reach a movement disorder clinic unless you are referred on. In India, you can directly go and approach a movement disorder specialist and seek treatment for your own problem. This is a very different to the North American setup where unless you're referred, you can't treat. So what happens is a lot of Parkinsonian patients will be referred by their friends, family, neighbors, because they said, "Oh, we got better, we went to this movement disorder clinic." So that referral bias is also going to be there. The third thing is when you look at referral bias, you also look at the dystonia group, and you see that we had 14% of the dystonias were dystonia patients. Now, dystonia is much less uncommon compared to tremor. But then you have the option of giving botulinum toxin in focal dystonia. You have the option of drugs or BBS strategies, which could be used for the more severe dystonias. So probably they do get referred on. So there is natural bias, but there's also a totally different pattern of where patients reach a disorder clinic in India versus the West, because you don't necessarily have to be referred by a doctor to reach a movement disorder specialist.
Yes, sir. Yes, sir. So, coming to the last question of this talk, sir. So, as you have already emphasized that Parkinsonism seems to be the major chunk of movement disorder practice in India. So, what is your advice to the younger generation to on building a team of dedicated allied services which are essential for treating Parkinsonian patients, like neuro rehab, speech therapy, and neuropsychological evaluation, and so on?
So I think your point is very well taken. I mean, when you're running a tertiary movement disorder center, we all need to build a team. In a teaching institute, either a government or corporate or private trust hospital, this is obviously much easier. In a smaller setup, you have to cobble up the team in the community and work with them. Not everybody can start out with a full team. But my suggestion is that however small your setup is, learn to have patients who you work with. They may not necessarily be part of your team to start with, and later on then you can build your own team. I mean, in the pandemic, we have been offering neuropsychology online, we are doing speech therapy online, and so these are resources which can be seated anywhere. So even if you don't have a resource in your town, city, or village, wherever you practice, the pandemic and video consultation has taught us that your resources can be anywhere. We have to learn to work as a team, and I'm sure we can do it. The IT companies are working with teams based all over the country. So why can't we?
Absolutely right, sir. So, actually, it was a very great pleasure to listen to you, sir. And I think the young neurologists have got many take-home points here on how to collect data very methodically, and also on how to plan to set up a movement disorder setup, especially when you're alone or like in a private setup, maybe because it may not be that difficult in a already well-established setup, but to set up as an individual, I think people have to learn from giants like you, sir. So thank you very much for sharing your valuable time with us. And so that's it from this episode of MDSI-Vaani, episode number 4. So please look ahead for the next video in the coming few days. Thank you.
Thank you. And I want to also thank my co-authors of the paper. I think this wouldn't have been possible without the efforts of Dr. L.K. Prashant, who really steered the whole thing and kept pushing us to complete all the missing data points and pushing us to to review the analysis. So I think without his and of course Dr. Rishikesh Kumar and Dr. Muthane, without whom this paper wouldn't have seen the light of day. Thank you. Thank you very much.
Thank you, sir. Thank you. Good night.